Hi guys, this is Dr. Patil and in today's video we'll be discussing about osteoarthritis, a small nonetheless important topic. Now that we are talking about NEET SS 2022, every small topic is as relevant as every major topic, right? So there's nothing that you can afford to ignore. Now from osteoarthritis, what you should know. According to me, particularly you should know about the Lawrence and Kellgren's grading of osteoarthritis. You should know a little bit about the pathogenetic process. Then you should know a little bit about its management. Right? Rest of the things are not particularly important. Now, what is osteoarthritis? Remember, the first part I am going to tell you is that this is the most common cause of arthritis. Overall, all forms of arthritis put together, this is the most common type of arthritis. And also remember that this is the second most common chronic musculoskeletal complaint. Right? This is the second most common chronic musculoskeletal complaint. You may ask me what is the first most common chronic musculoskeletal complaint? That is about back pain. Right? Chronic low back ache. Chronic LBA is the most common musculoskeletal chronic complaint. Okay. Now, what is osteoarthritis? Osteoarthritis is basically a degenerative joint disorder. That also means that this is a non-inflammatory joint disorder, right? So all the characteristic distinguishing factors that we were discussing between inflammatory versus non-inflammatory joint disorders, well, those points hold good here. So this is a non-inflammatory joint disorder. Non-inflammatory joint disorder, right? Okay. Now, what are the risk factors for osteoarthritis? Well, the age is the most potent risk factor, right? Let me make this statement again. Age is the most potent risk factor for osteoarthritis. Okay. In fact, there are hardly few situations where you may get osteoarthritis before the age of 40. Right? So otherwise, most of the cases of osteoarthritis are diagnosed after 40 years of age. Typically, like if the osteoarthritis is triggered by the joint trauma or joint instability, right, or malalignment, then you may encounter osteoarthritis before the age of 40 years. Otherwise, you are diagnosing osteoarthritis after the age of 40 years. Female gender is an important risk factor, especially postmenopausal women are particularly more at risk. Postmenopausal women are particularly more at risk. And we all understand the importance of obesity. We know that the weight-bearing joints are very frequently involved in case of osteoarthritis, and thus obesity is an important risk factor. Right? So probably this is the second most important risk factor after age. After age, this is the second most important risk factor. And if they ask you what is the most common modifiable risk factor, obviously that is obesity, right? Now, coming to genetics, genetics probably doesn't play an important role, maybe a minuscule role, but we still have observed certain findings in the sense that there is a subtype of osteoarthritis called as nodular or generalized nodular osteoarthritis, which is seen to cluster in families. That typically affects females more and has a tendency to have a familial occurrence. So thus, there may be some role of genetics. So far, what we have observed is that certain polymorphisms in gene called GDF5, right? Polymorphisms in gene called GDF5 that confers higher risk of developing osteoarthritis. Apart from that, if you talk about HLA, HLA-A1 and B8 are considered as risk factors. Right. So remember, when we talk about other rheumatological disorders, especially the inflammatory arthritis like rheumatoid arthritis and other rheumatological disorders like SLE and all, very often we talk about HLA-DR-B1, right? HLA-DR-B1. If I have to talk about rheumatoid arthritis, probably HLA-DR4 also, right? But in case of osteoarthritis, it is HLA-A1 and B8. A1 and B8. They carry a slightly higher risk of developing osteoarthritis. Okay. Then there is also some relation between having this alpha-1 antitrypsin, M2 phenotype and a slight higher risk of developing osteoarthritis. Okay. And the genome-wise association studies have found out certain loci on chromosome 2q, which basically houses the genes for interleukin-1 and its receptor alpha. Right? So certain polymorphisms in this location can confer a higher risk of developing osteoarthritis. Right? So that is about genetics. Now coming to another risk factor, that is trauma. Trauma is also considered as an important risk factor. So if there is, like, if a patient has suffered mainly fractures running through the joint surface, that is a very, very important risk factor for developing osteoarthritis. Similarly, if there are joint malalignment, then the joint would be subjected to repeated trauma, and that is also considered as a risk factor. Okay. Then repeated use of joints and exercises can also be considered as risk factors. Repeated joint use and exercise. For example, hip joint osteoarthritis is very common among farmers because they are repeatedly subjecting their hip joint for use, right? So these are the risk factors. Now coming to pathogenesis. Pathogenesis can be described in very complex terms, but let me try to simplify it. The key point that you should remember. Okay, so the main pathogenic process is that because of the repeated trauma, repeated weight bearing, the joint cartilage is subjected to wear and tear. And from the wear and tear, the matrix proteins are released into the synovial fluid. And these matrix proteins, the products of wear and tear, often stimulate chondrocytes to produce inflammatory cytokines. Okay. So what cells are secreting the main inflammatory cytokines? It is the chondrocytes. So remember this point. So chondrocytes are the ones which are secreting the cartilage matrix. So the most important structure that is damaged in case of osteoarthritis is obviously cartilage. Other structures are also involved. Right? So there is involvement of bone in the form of sclerosis, subchondral cyst formation, and also new bone formation. There is also involvement of the other structures, including synovial. Synovial inflammation is known to occur, and also the muscles which are kind of supporting the joint can also get wasted. So all the joint structures can be involved, in simple words. But all the pathogenic processes are starting from the cartilage. Cartilage damage is the hallmark of osteoarthritis, right? So we know that cartilage is secreted by chondrocytes. The matrix of the cartilage is secreted by chondrocytes. So just like how we have osteoclasts and osteoblasts regulating a fine balance of bone formation and bone resorption, similarly, chondrocytes kind of balance the matrix formation and matrix degradation. So they secrete substances which have a tendency to degrade matrix also. Those substances are called matrix metalloproteinases, right? As the name suggests, they are breaking the protein. Those typical two examples I want you to remember is collagenases, which block or degrade the collagen, and ADAMTS 5. Right? Remember that the collagen type that is seen in cartilage is type 2 collagen. Okay, so remember this point. This can be asked as an MCQ. Type 2 collagen. Okay. Now, once these matrix proteins or wear and tear particles are released into the synovial fluid, they stimulate some of the synovial cells as well as the chondrocytes to produce inflammatory cytokines. Right? What are the inflammatory cytokines? Numerous of them, but particularly you should remember interleukin. If you want to remember with little more precision, I want you to remember interleukin 1 beta. Right? Interleukin 1 beta. This inflammatory cytokine actually stimulates conversion of the inactive matrix metalloproteinases, which were secreted by the chondrocytes, into active matrix metalloproteinases, which will degrade the matrix and cause cartilage damage. Right? That is the simplest thing. Apart from this, another important cascade that is involved in conversion of inactive matrix metalloproteinases to active matrix metalloproteinases is plasmin. Okay, so plasminogen is converted to plasmin by tissue plasminogen activator, which can also be stimulated, as you can see from the screen, by the interleukin 1. Okay, so thus interleukin 1 is the most important inflammatory cytokines in case of osteoarthritis. Right? So if you have to talk about inflammatory cytokines, for example, if I have to talk about rheumatoid arthritis, right? If I have to tell you that pick up one important inflammatory cytokine, you should say TNF alpha, right? In fact, our treatment strategies are targeting this path, right? Similarly, if I have to tell you that pick up one inflammatory cytokine that plays the crucial role in the pathogenesis of systemic sclerosis, what comes to your mind? Transforming growth factor beta, right? TGF beta, right? So similarly, in case of osteoarthritis, that single most important inflammatory cytokine is interleukin 1. For those who want to be more precise, it is interleukin 1 beta. Okay. Yeah. So this is about the pathogenic process. I also want you to remember that a significant number of patients, maybe like up to 2/3 number of patients, I can say 1/3 to 2/3 patients with osteoarthritis have CPPD crystal deposition or evidence of presence of CPPD crystals in the synovial fluid. That means they have chondrocalcinosis, right? So chondrocalcinosis is also an important risk factor. I should mention it here. Chondrocalcinosis is also an important risk factor for patients developing osteoarthritis, right? Okay. Now, let us move to discuss the pathology. What pathological abnormalities we see? What are the important MCQ points? The first and the most important MCQ point I want you to remember is that the earliest pathological finding is presence of cartilage fibrillations, right? What is that? Presence of cartilage fibrillations. So in the cartilage, you can compare both the images that you're seeing on the monitor, and you can notice that in the cartilage, there are certain fibrillating damages present, right? We call it as surface fissures or fibrillations. Basically, there are fissures on the articular cartilage surface. That is what we call as fibrillations, and that is the earliest sign that we notice. Okay, that is one important point to note from the pathology. The second point I want you to note is that there is something called as tide mark duplication, right? So this question can also be asked. The tide mark duplication is characteristic of which of the following joint disorders? Rheumatoid arthritis, psoriatic arthritis, and osteoarthritis. So remember, it is about osteoarthritis. So what am I talking about? I am talking about tide mark duplication, right? I'm talking about tide mark duplication. What is it? Normally we have this tide mark. What is tide mark? That is basically interface between calcified cartilage and the articular cartilage. This interface is called tide mark. In case of osteoarthritis, that is increased, right? So there is, you can see the two layers of this interface, right? That is what we call as tide mark duplication. There is duplication of this tide mark, the interface between articular and calcified cartilage. Obviously, the other findings like subchondral bone sclerosis and cyst formation may be evident on the histopathological specimens also. So, two important MCQ points. Earliest finding is articular surface fibrillations or fissuring, and tide mark duplication is hallmark or characteristic of osteoarthritis. Okay, that's all from the pathology. Now let us discuss the clinical features. What are we expecting? Obviously, patients present with joint pain, that is the most common complaint, right? And remember, the joint pain may be accompanied with early morning stiffness, and because this is a non-inflammatory disorder, the early morning stiffness usually lasts less than 30 minutes. In case of inflammatory disorders, it usually lasts more than 30 minutes, often lasts more than 1 hour, right? But if you are seeing early morning stiffness, that does not rule out osteoarthritis. It can be seen, but the duration is the most important thing to note. Okay, then there may be joint swellings, but the swellings are usually, remember this again, the swellings are usually bony. The swellings are usually bony. Okay, because in case of rheumatoid arthritis, the joint swelling is mainly because of the synovial structures, right? Synovial fluid accumulation and swelling. In case of osteoarthritis, the swelling is mainly bony. I told you there is increased bone sclerosis as well as there is new bone formation, osteophytes, right? The most commonly affected joints in case of osteoarthritis are, right? Remember, all these are MCQ points. Let me make the first point. There is characteristically involvement of first carpo-metacarpal joint, right? What am I talking about? Carpo-metacarpal joint, the joint that is there in the base of the thumb, right? Its involvement is very, very characteristic of osteoarthritis. You don't see that frequently in other arthritic disorders, right? And in fact, this may be the first joint to get usually affected in case of generalized osteoarthritis, right? Okay, that is the first point. Then apart from that, there is involvement of proximal interphalangeal joint and distal interphalangeal joints. These are also very commonly affected. Now, when it comes to involvement of distal interphalangeal joints, we are very much aware that DIP is spared in case of rheumatoid arthritis, right? So, DIP involvement, one important condition is osteoarthritis. The other condition where DIP involvement may be seen is in patients with psoriatic arthritis, right? In patients with psoriatic arthritis also there is characteristically involvement of distal interphalangeal joint. Now, how do we differentiate? Usually it is not a challenge because psoriatic arthritis patients also have the psoriatic skin manifestations and they may have those nail changes. So clinically not a challenging task to do. Okay, coming to large joints, obviously involvement of knee joint is probably the commonest large joint that is involved. Then there may be involvement of hip joint, particularly certain occupations like farmers, and hip joint osteoarthritis is relatively more common in the Caucasians in the Western world in comparison to India. Okay, but obviously knee joint involvement is very, very common across the globe because of the obesity and weight bearingness that this joint bears the brunt of the weight, right? So there is involvement of first carpometacarpal joint, there is involvement of PIP and DIP, there is involvement of knee and hip joint. What joints are usually spared? Right? The joints that are usually spared include wrist joint, ankle and elbow. These are the joints which are very, very frequently involved in case of rheumatoid arthritis, right? So just by looking at the distribution of the joint involvement, we can differentiate between rheumatoid arthritis and osteoarthritis. Obviously, we have those additional findings of inflammatory versus non-inflammatory arthritis, right? In fact, that wrist joint involvement is probably the first joint that gets involved in case of rheumatoid arthritis. We know that in case of rheumatoid arthritis, distal radioulnar joint is the one where we probably can identify the earliest changes of the arthritis, right? Okay. Now, we also know that there is one subtype called as nodular osteoarthritis, or you can say generalized nodular osteoarthritis. I was already talking about it when we were discussing genetic factors. I told you that this generalized osteoarthritis often is seen in familial clusters, right? So that means in that variant, there is a lot more involvement of genetic contribution, right? And in this generalized variant, we see these characteristically named two nodes, right? The first one is Bouchard's nodes, and the second one is Heberden's nodes, right? Bouchard's and Heberden's nodes. Now, from the MCQ perspective, what really confuses students is which one is Bouchard's, which one is Heberden's, right? So Heberden's nodes are basically, I will give you a simple hack. You know the alphabetical order A to Z. So in the alphabetical order, B comes first and then comes H, right? So if you remember this, B, because it comes first, it more characteristically affects proximal interphalangeal joints, right? So remember, Bouchard's mainly affects proximal interphalangeal joints. Now H comes distal to B in alphabetical order. So Heberden's node starting with H mainly affects the distal interphalangeal joints, right? So I hope you will be able to remember this, right? And the occurrence of this is characteristic of generalized nodular osteoarthritis, right? Nodular osteoarthritis. 2 points to note about this: very, very significant female preponderance, and there may be little bit of familial clustering. Okay. Now coming to the radiological findings that we would see in patients with osteoarthritis in their osteoarthritic joints, right? So let us take the knee joint as an example. I want you to remember some important points. The earliest radiological change that we see is an MCQ point, right? The earliest radiological change that we see is joint space narrowing, right? Joint space narrowing. That is the earliest radiological change. Why joint space narrowing? Obviously, the cartilage is being destroyed, thus the joint space is getting narrowed. Okay, but if they ask you what is the hallmark, radiological hallmark of osteoarthritis, right? In that case, my answer would be the radiological hallmark of osteoarthritis is formation of new bone, what we call as osteophytes, right? That is the radiological hallmark of osteoarthritis. What additional changes we see? You can notice from this image there is joint space narrowing. In comparison to the opposite side, there is joint space narrowing. The other thing you can notice from this joint space narrowing is there is non-uniform joint space narrowing. The joint space narrowing is not usually uniform. It is non-uniform because the cartilage destruction is also not uniform. The sides where there is more weight bearing, the destruction will be more. So this is the point to note. Apart from the joint space narrowing, we can see some osteophyte formation. Probably it may not be very clear in this image. I will try to see if I can pick up another image where there is clear osteocytes being present. Okay. Then I told you that this destruction from the cartilage often spreads to bone, and once the bone is affected, bone responds by forming sclerotic bone, right? So you can see subchondral bone sclerosis. You can clearly appreciate the sclerotic changes, right? In this area there is a subchondral bone sclerosis, right? Apart from what you can see is there may be subchondral bone cyst formation. I hope you will be able to appreciate the margin of this subchondral cyst. So these are the four important radiological findings: bone sclerosis, subchondral cyst formation, osteophyte formation. Probably you can appreciate osteophytes little better here if it is visible. That is the marginal osteophytes, and obviously the joint space narrowing. These are the radiological findings that we would see in patients with osteoarthritis. Okay. Now with this, let us understand the radiological grading of osteoarthritis. But before I go there, I just particularly want you to focus on this image. Look at this image. What are we seeing? This is the base of the thumb, right? So thus this is the first carpo-metacarpal joint. And you can notice that there is osteoarthritic changes. There is a joint space narrowing here, right? I hope you are appreciating that. There is a non-uniform joint space narrowing suggestive of osteoarthritis, and involvement of first carpo-metacarpal joint, I have already told you, is very, very characteristic of osteoarthritis. So this could be a potential image-based question, so be aware about it. Okay, now coming to the radiological grading of osteoarthritis. It is a named grading system, and the name of the grading system itself can be asked as an MCQ. That is Lawrence and Kellgren's classification of osteoarthritis. Okay, Lawrence and Kellgren's classification of osteoarthritis. So there are basically 4 grades, and we have to be aware of these grades, and 3 or 4 important MCQ points that can come from this grading system I will also be telling you. Okay, but before I go on to dissect these branches or these grades, let me tell you to remember one important point. When I was telling about the radiological findings, I told you that the earliest manifestation is joint space narrowing, but when it comes to this grading system, just remember one hack or a simple trick for us to remember or reconstruct this table. I'm telling you this hack, this is not a fact. Osteophytes lead the joint space narrowing. What do I mean by that? With this statement, what I mean is osteophytes appear first and joint space narrowing appears next. But this is just a hack to remember this table, not in real sense. In real sense, joint space narrowing is the earliest radiological finding. Okay, so what happens in grade 1? In grade 1, there is doubtful narrowing of the joint space. There is doubtful narrowing of the joint space. So we are talking about mainly 2 radiological changes in this grading system. The first one is joint space narrowing. The second one is osteophytes. And if you know the relativity between these two, you can reconstruct this table. Right? So in grade 1, there is doubtful narrowing of joint space, possible osteophytic lipping. That means osteophytes are just about to be appearing on the sides of the bone. But probably there is not much of joint space narrowing. It's like quite doubtful. What do I mean by that? In grade 1, osteophytes, कुछ evidence मिल रहा है. There is some evidence of osteophytes. Nothing much about joint space narrowing. So I told you, right, in case of this grading system, osteophytes are leading in front of joint space narrowing, right? In grade 2, what happens? The osteophytes become definite. There are definite osteophytes, and this is an MCQ point. Finding definite osteophytes is characteristic of which of these grades? That is grade 2. Okay. What happens to the joint space narrowing in grade 2? It is possible. We started with possible osteophytic lipping in grade 1. So osteophytes, the wording possible started in grade 1 itself. The wording possible for joint space narrowing appears first in grade 2. Right? What happens in grade 3? we have definite joint space narrowing. So the joint space narrowing becomes definite in grade 3. Osteophytes become definite in grade 2. Right? This is the relation for us to remember. And in terms of osteophytes, they are moderate and multiple. So when we were talking about grade 2, we were only talking about, okay, definitely there is osteophyte, even a single enough. But in grade 3, there are moderate in size and they are multiple in number. And there is definite joint space narrowing. Okay. Now in grade 4, what happens is there are large osteophytes and there is marked joint space narrowing. Another thing I want you to remember from the grade 4 is there is definite bony end deformity. Right? If I take you to the previous X-rays, you can notice that there is some bone end deformities. The bone end is not uniform, so there are some deformities. Those deformities become very, very definite in case of grade 4 of the Kellgren and Lawrence classification, right? So I hope you are now understanding. So 3 important MCQ areas. First one, definite osteophytes, grade 2. Definite joint space narrowing, grade 3. Definite bone end deformities, grade 4. Right? Clear? Okay. Even if an image-based question is given, you should be able to appreciate which grade it is, looking at the joint space narrowing and possibly presence of osteophytes and bone end deformities. Okay. Now coming to investigations, the most commonly performed investigation is obviously X-ray. I understand that CT and the MRI may be able to give a better information about the joint structures, especially the soft tissues and cartilages. But since the presentation is very, very characteristic and we generally don't get confused between osteoarthritis and other closely related rheumatological disorders because of the characteristic joint distribution and presentation and the non-inflammatory features, probably X-ray suffices in most cases. Okay. Just for the sake of completion, let me summarize the important X-ray findings. The most common or the earliest X-ray finding is obviously joint space narrowing, right? Joint space narrowing. That is the earliest X-ray finding. Apart from that, we also see new bone formation in the form of osteophytes, and we also know that this is the hallmark of osteoarthritis, right? Apart from these 2 important findings, we also notice that there is subchondral sclerosis and there is also subchondral cyst formation, and sometimes there may be presence of loose bodies, right? These are the X-ray findings we are noticing. If at all you do synovial fluid analysis, what are we expecting? I told you this is a non-inflammatory arthritis, and obviously that means the WBC count is going to be less than 2000 cells per cubic millimeter. I had also told you that chondrocalcinosis is an important risk factor that can be seen in up to 1/3 to 2/3 patients. That means 30 to 70% of these patients may have CPPD crystals in their synovial fluids. Right? That's about investigation. Now coming to its management. Management strategies can be divided into 3 broad headings. The first one is non-pharmacological management, and obviously because this is a disorder where there is some role of obesity, weight loss and exercise become important strategies, right? Weight loss and exercise. So weight loss can be achieved with diet, pharmacotherapy, surgical management of the obesity, as well as exercise. One gray area or a controversial area about osteoarthritis and weight loss management is that exercise, because repeated use of joint, is known to be a risk factor for worsening of the osteoarthritis. How far it is logical to subject these patients to exercise? But now most of the professional guidelines do agree that at least in the early phase of osteoarthritis, where the joint damage is not extreme or severe, we should go for weight loss, because it is believed that weight loss is the leading cause for osteoarthritis and not the outcome of osteoarthritis. What do I mean by that is that in reality, obesity is leading to osteoarthritis, and it is not that osteoarthritis, because of the apprehension of pain, the patients are not walking, and that is leading to obesity, right? So if you achieve some decent weight loss, you may be able to slow the progression of osteoarthritis, right? So weight loss should be actively encouraged, and exercise should also be encouraged as long as patient is able to bear the pain or patient is able to bear the exercise. and it is not going to cause much of the damage to the joint. Okay, so what exercise are preferred? The preferred exercise are basically aerobics, obviously the very important exercise mechanisms for weight loss, and you can also encourage resistance training, right? And this exercise are also helpful because remember, the weakness of the supporting structure of the joint is also considered as a risk factor for osteoarthritis. So if the muscles and the ligaments and tendons are weak, that can also increase the risk of progression of osteoarthritis. So properly designed exercise regimens may strengthen those muscles. For example, quadriceps weakness, right, increases the risk of developing knee osteoarthritis. So if you train the quadriceps muscles well, your chances of developing or progressing the knee osteoarthritis reduces, right? So there is importance of exercise. The second important heading for the management is nutraceuticals. Right. So we will discuss about pharmaceuticals later, but first let us discuss about nutraceuticals. What are commonly used? Commonly, hyaluronic acid or chondroitin sulfate, hyaluron sulfate, and these are all available as nutritional supplements, right? And orthopedicians, rheumatologists, physicians continue to prescribe them. But American College of Rheumatology, right? American College of Rheumatology recommends against use of nutraceuticals because most of the major studies have failed to show any benefit of use of these nutraceutical substances like hyaluronic acid or chondroitin sulfate. I do agree that they are integral part of the joint structures, but supplementing them through diet has not shown any benefit, so we don't go for it anymore. Okay, the controversy is over. Currently, the assumption is that they are not going to be helpful. Now coming to pharmacological management. Obviously, the first point to note is NSAIDs continue to play an important role because they are the mainstay of pain control, and we do consider, obviously one should be aware about the long-term use of NSAIDs and the side effects that come with that. The second class of drugs, disease-modifying osteoarthritis drugs. Just like how we have DMARDs for rheumatoid arthritis, we have disease-modifying osteoarthritic drugs. And I want you to remember only one particular drug. The drug I am talking about is diacerin. Right. So what is diacerin? Diacerin is an interleukin-1 inhibitor. It is believed to work by inhibiting interleukin-1 action. Okay. So we were discussing about the role of interleukin-1, right? That is the most important cytokine. So diacerin basically blocks it. And it has shown some benefit, so guidelines do recommend its use. Though not as the mainstay of treatment, they do recommend, although they do favor the use of this agent. Okay. Now coming to certain newer drugs. I want you to remember two drugs particularly. The first one is Faciti-Bunt. Does it sound familiar? Yes, I was talking about one Bunt drug when I was talking about hereditary angioedema, right? So this is also working with a very similar mechanism. This is a bradykinin 2 receptor antagonist. It's a bradykinin 2 receptor antagonist. So the other Bunt I was talking about was Icatibant, right? The other Bunt I was talking about was Icatibant, which is used for treatment of hereditary angioedema, which is also a bradykinin 2 receptor antagonist, right? Now this has been used for treatment of osteoarthritis as well as osteoporosis. Okay. The second newer drug which is finding some favor is tanezumab. What is this? This is a monoclonal antibody against nerve growth factor. Okay. Now, when I was discussing pathophysiology, I didn't go too deep into the mechanism, simply because from the physician that much of understanding is not expected. But one point I missed and I want you to remember is that there is some role of nerve growth factor in the pathogenesis of osteoarthritis. Okay, and we understand this from the fact that, Charcot's arthropathy. In those cases, because of the injury to the nerves, the chance of developing severe osteoarthritis increases. So we understand that there is some role of nerve injury also in the pathogenesis of osteoarthritis, right? And the link may be through this nerve growth factor. So monoclonal antibodies targeting this nerve growth factor have shown some benefit in earlier phase of trial. So this is an emerging drug, tanezumab, which is a monoclonal antibody against nerve growth factor. So this is all we should know from osteoarthritis. Obviously, there is a role of surgery, which is not particularly important from our perspective, right? So we will be discussing another important topic in the subsequent videos. Thank you for patient listening. Have a good time.